you can literally sculpt the dose to the contours of the tumor.
Sometimes the patients don't need chemotherapy either. Is that right?
Women with cervix cancer, literally putting the radiation source close to the skin.
The person who told me about it said to me that I went to the doctor in the morning, had the radiation, and then I was out with my family for a meal. Now that was unheard of earlier. When we think about cancer treatment, it's like going down a crazy rabbit hole. It's so confusing, it's so upsetting. You know, your nervous system is fried anyway. So, what we're going to talk about today is actually radiation therapy. And many of us still imagine these long, exhausting treatments when it comes to radiation, repeated hospital visits, difficult side effects, and the fear of how much the body may have to go through. But cancer treatment is changing, and radiation is becoming more precise, more carefully planned, and more tailored to the individual patient. Doctors are now thinking about how to treat the cancer with greater accuracy and to protect more of the surrounding body. And they're thinking about how to preserve quality of life during and after treatment. So, one of the important shifts is the move towards more focused and shorter forms of radiation therapy. Today, on the Wellness Algorithm from Wellness Curated, we'll explore how radiation therapy is advancing, what makes treatment more precise, and where different cutting-edge forms of radiation fit in, and what these developments can mean for patients. To help us understand that, I'm joined today by Dr. Madhur Garg, who's a radiation oncologist based in the US, and his work focuses on advanced cancer treatment and precision radiation. Welcome to the show, Dr. Garg. Thank you so much for taking the time to be here with us today.
Thank you for having me. It's a pleasure, and I'm looking forward to a productive conversation today.
Fantastic. I'm delighted that you're here. Now, I'm going to start with the very basics because I think, like I said in the introduction, a lot of people hear the word radiation and they start freaking out. You know, they have this picture of a particular kind of treatment. So I want you to tell us, how has radiation therapy changed in recent years? What was it and what is it today?
Yeah, that's a great question. And you would be surprised how many doctors who are not in our field have not seen a radiation machine. Forget about a patient who's
Wow.
coming into the department the first time. So, just broadly, the machines have gone very significant transformation over the years, especially in the last 30 years or so.
Right.
Radiation machine of today looks like a CT scan machine, literally a lot more open though. So
Right.
there's less likelihood of patients getting claustrophobic, and it's just like a CAT scan. You lie on a table, the machine rotates around you, gives radiation for a few minutes, patient gets up and goes home. So overall, technology really has changed how we deliver radiation very significantly.
And I'm going to ask you a silly question. Does it hurt the patient when you give them radiation?
Again, an excellent question. A lot of patients ask us that. It's like getting x-rays. Radiation is like getting x-rays. So overall, radiation is high energy x-rays. You don't see or feel anything. You lie on the table, as I said, and the machine goes around, gives radiation for a few minutes. Uh, it does not hurt. You don't feel any heat, literally nothing.
And tell me, what are some of the biggest advancements that have made radiation more precise than it used to be, which is really the focus of what we're going to be chatting about today?
Yeah, so when I started, in fact, I started in the early 90s in this field. We were towards the end of the old technology where we were using literally surface markings to treat the tumor inside the body. So we'll basically look at the scans of the patient, then figure out how deep the tumor is inside, draw a field on the skin of the patient based on that the location of the tumor inside the body. So we call we used to call that surface anatomy, and treat basically based on the surface anatomy. Then came three-dimensional radiation in the 90s, where you could do a CAT scan or a MRI and plan the radiation of the scan. So on the scan, you would say, okay, this is the area you want to treat. You would contour or define the area and then set up the beams from outside. So that was the second level. The third level was where we were able to modify the intensity of the radiation beam. So initially, the radiation beam was all uniform. So the entire region would get the same dose of radiation. If I were to treat, for example, throat or tongue, I would create a box around the tumor and treat the entire box with the same dose of radiation. With three-dimensional radiation and intensity modulated radiation, where you could modify the intensity of the beam, we were able to, or we are able to now sculpt the dose to the contours of the tumor. So because the tumor is not a box or a circle, it's all uneven. So what we can do now is identify the tumor on these advanced images of CT scan, MRIs, PET scan. We use all
Right.
advanced technologies for imaging. On that, we contour the tumor, whatever the contours are, however irregular they are, and then plan of that. And with this intensity modulated radiation beam, you can literally sculpt the dose to the contours of the tumor, thereby giving a high dose to the tumor and reducing the dose to the surrounding normal structures. So the advancements have come in both uh, areas. One is imaging based, so you can identify the tumor so much better now. And second is delivery techniques, where you can modify the intensity of the beam to sculpt according to the tumor contours.
So, Dr. Garg, one of the reasons I'm having this conversation with you is because I know a few people who went to Dr. Greco in Portugal, and they have raved and raved about the treatment, about how easy it was. So, what I want to ask you now is, when you're planning radiation treatment for a patient, what factors shape the decision? For example, the tumor, is it the tumor type? Is it the stage of the cancer? Patient's overall health? Do all these things affect your plan?
Yes. So, and again, every tumor is different, every patient is different. So the first step is identifying what stage the patient is in. Is the tumor localized? Has it
Right.
spread out in the local area, or has it spread out in the body? And based on that, you define what areas you're going to treat with radiation. And as I said, every patient is different, every tumor type is different, and aggressiveness is different. So once we ascertain the stage and the aggressiveness of the cancer based on hundreds of studies done over the years, we know, okay, this particular tumor, this particular location needs to get this much dose of radiation. And this dose of radiation can be given over a few days, one treatment sometime, or over few weeks. So this whole process of first identifying what area to treat,
Hmm.
then how much dose and how you're going to do it is all curated or personalized based on the patient's anatomy, based on the patient's condition.
Wow. And I'm going to ask you another question here. From what I'm hearing, the sort of radiation that you do, the precision radiation, sometimes the patients don't need chemotherapy either. Is that right?
That's true. There are lots of cancers where you don't need chemotherapy and the patient can be treated with curative intent just using radiation without any surgery, without any chemotherapy.
Wow, that's fantastic. So, before I carry on further, I want you to explain a few of the different kinds of radiations to me, these names of these new kinds of radiations that are floating around, like stereotactic radiation, short course radiation, and then, of course, what you do, which is brachytherapy, right?
Yes, that too. So
Yeah.
historically, radiation was done over weeks, would be done over 5 to 8 weeks, every day, 5 days a week, sometimes 6 days a week, little by little every day. And that was the standard way of delivering it because and the reason was that you were treating a bigger area
Mm-hmm.
and the surrounding structures were getting a higher dose of radiation. So you would do little dose every day with the premise that the little dose is going to affect the tumor, but not going to affect the normal tissue around it on a daily basis. And the normal tissue recovers next day when you come for the treatment, whereas the tumor does not, because the tumor cells don't recover that well
Right.
from that low dose. So that's why you used to do little by little radiation every day over 5 to 8, 9 weeks sometimes.
Wow.
Now, what has happened was, yep, yeah. So now what has happened with this technology, with imaging, with the delivery techniques, you can really focus the radiation and treat it within millimeter precision. So what that has done is uh, reduction in the total number of treatments. So every day the patient is getting a higher dose of radiation, but the total number of treatments or the duration is becoming shorter and shorter to a point that a lot of cancers now can be treated with 1 to 5 treatments. So some can be just treated with one treatment. Some
Yes,
can
that's
be
what I'm
treated
hearing.
with 3 to 5. Yeah.
Because the person who told me about it said to me that I went to the doctor in the morning, had the radiation, and then I was out with my family for a meal.
Yes.
Now, that was unheard of earlier.
Yes. Yes. Yeah. I'll tell you that nowadays patients uh, come during their lunch breaks, will come in the morning before their work or after their work, get treatment, and go back to work. So things have changed very significantly in a lot of cancers where you can really pinpoint the radiation, focus the radiation in a way that the side effects are minimal, quality of life is unaffected, and the cure rates are very high. In a lot of cases, better than surgery. So
Amazing.
overall, when you look at the balance of cure rates and side effects, that balance is shifting a lot in favor of radiation because the side effects or the downtime is much less as compared to what it used to be, or even now with treatments like surgery.
And the three different types of radiation which people are talking about, the brachytherapy, the short radiation, and the stereotactic radiation, is that just something that the doctor decides which one is relevant, or is there like a drastic difference between them?
No, it depends on what you are treating and what area needs to be treated. So, for example, brachytherapy is something which is done close to the body. Brachy means close, right? Close to the body and therapy. So in brachytherapy, what you do is you put radiation sources
Mm-hmm.
close to the body or inside the body in the cavities. So it's used for skin cancers, for example, because you can see the skin, you know what needs to be treated. You don't need to go very deep inside the body. So you put a radiation source on the skin.
Mm-hmm.
Okay. And there are technologies and techniques how to do that. But you're literally putting the radiation source close to the skin for a few minutes, taking it off, and that's it. It does not go deep in the body, it treats the surface, and the patient is done. Similarly, in patients where you need to treat inside a cavity, for example, in women with cervix cancer or uterine cancer, we treat inside the cavity, put a radiation source inside the cervix through a thin tube for a few minutes. It treats from inside out. You take out the source and the patient goes home. Again, it can be done over one treatment. Sometimes it needs 4 to 5 treatments. That's brachytherapy given close to the body. In some cases, we put radiation sources and just leave them in. In prostate, for example, we have these tiny radiation sources, like the size of a rice grain, and we insert them inside the prostate, leave them there. They give radiation over a period of a few weeks from inside out, and then they decay, and the
Wow.
radiation from that goes away, and that's about it. So the patient does not have to come in back and forth every day for treatment. So that's another type of brachytherapy because it's done close to the body.
Okay.
Stereotactic or intensity modulated radiation therapy are done using these machines, which are delivering basically high energy X-rays, which are coming from outside in. Right? Brachytherapy is inside out or on the surface.
Right. Tell me something now that the patient may not even need chemotherapy. Typically, tell me what are the side effects of the new precision radiation therapies that we're talking about?
Mhm. So the side effects of radiation depends on what area you are treating because you're very precise now. So, one misconception is, oh, you lose your hair when you get radiation.
Right,
So I tell patients, you'll only lose your hair if I'm treating the head, right, or the
right,
skull. If
right,
I'm
right.
treating any other part of the body, the
Mhm.
side effects are related to that particular region and what normal structures are there in that region. So, for example, if I'm treating head and neck or a tongue cancer, side
Mhm.
effects will be related to the mouth or mucosa. So, patients might have a little soreness or dryness in the mouth. The skin over here on the side might get a little dark.
Mhm.
So that those are the side effects. In prostate, when you're treating the pelvis, patients might have some urinary issues or some bowel issues. But again, because of the precision associated with these new technologies, the likelihood of these side effects have very dramatically dropped. So, for example, when we did old technology, 40-50% of the patients would have significant side effects in
Mhm.
prostate cancer patients. They would say, oh, I'm noticing some blood in the urine or the blood in the stool. Now, with the new technology, it's less than 1% that anyone will have blood in the urine or blood in the stools. So that's the dramatic decrease in any serious side effect which used to happen in the past with radiation.
Wow, that is just amazing because but why is it? Can I ask you why is it that people don't know enough about this? People still think I mean, even I didn't know so much about it till I had friends who went to Portugal and then told me. And I was blown away. So why don't enough people know?
Yeah, I think it's the advancements, first of all, have happened so quickly that
Mhm,
people have not been able to keep pace with the advancements, especially in other specialities. In medical school, for example, there are no organized rotations in radiation oncology department. So if a medical student wants to take an elective, they can
mhm,
come to our department to see what radiation oncologists do, but
mhm.
there's no mandatory elective. So we are trying on the medical school level to see how we can go and give lectures in the school, tell them about radiation. So we've started doing that over here. So
Right.
that's one reason, because people don't know right from the beginning. The second is the patients don't come directly to us. So
Right.
patient has some sort of a cancer, their primary doctor will diagnose or suspect, will
Mhm.
send to the surgeon, right? And the surgeon is the one who basically is the person telling them about the treatment options. And that could be sometimes counterproductive. The surgeon doesn't know or has an inherent bias. It becomes difficult for them to tell all the options and discuss everything. So that's also in an academic place like ours, we're trying to address by discussing patients in a multidisciplinary tumor board. So all the specialists are there and trying to figure out what the best option for the patient is going to be. And now I'm
Right.
hoping with technology and with AI and all these advancements and awareness, this is bound to get better. But you are absolutely right. The awareness still is not there. In fact, there was some data recently where we
Mhm.
started looking at, or people looked at, if, for example, there were 100 cancer patients who would benefit from radiation, how many of them really get radiation? And the number is 50 to 60%.
Oh my
Because,
God.
yeah, because patients don't know, or they are unaware, their doctors are unaware, and they get something else or are not referred to us.
You know, we've spoken about this in a few episodes actually. We did an episode on integrated cancer care. And one of the biggest issues that cancer patients have is that they're sent from one doctor to the other doctor to the other doctor. And exactly what you're saying, there's no integrated care that's happening. So they're seeing individual people. And even for them to find out what is available is like this crazy rabbit hole. But I want to ask you another question about radiation therapy. Now, in the traditional older radiation treatment, there was huge amounts of planning involved before the treatment, before the patient got there and had the treatment. Is that the case with modern radiation therapies as well?
The amount of work has only increased when it
Interesting.
comes to the planning process and what we do behind the scenes.
Mm-hmm.
It's the technology which has shortened everything, right? The time it takes, because a lot of it is computerized now.
Mm-hmm.
So, when we decide, okay, this patient needs treatment, or this patient is going to benefit from this treatment, we discuss the options, discuss what is going to happen, the whole process with the patients, risks and benefits. So we spend all that time. Then the first step is a planning session where the patient gets a scan, gets an immobilization device. So if he's going to get head and neck radiation, we make a mask for the patient, and then we do a scan of the area, the head and neck area, and sometimes it's just a CT scan, sometimes it's a combination of CT, MRI, and even PET scan. So we
Okay.
do those scans, fuse all of those scans together in the computer in the back, and then define the target. Okay, this is the region I'm going to treat with 100% of the dose. This is the region I need 70% of the dose, because there might be some microscopic disease in this area. So we define those regions, then we define the normal structures. So, okay, the parotid gland or the spinal cord can only take this much dose. So we define those and make give constraints to those structures, the normal structures. Once all that mapping process and defining process is done, we have a team of physicists who do the plan, who basically set up the radiation beams on that scan to see which direction they need to bring beams, what intensity the beam should be, how many beams they're going to use to deliver that dose to the tumor
Right.
and avoid dose to the non-normal structures. They do all of that. They come up with the best possible scenario. They show it to the physician. The physician likes it, approves it. Then there is a dry run or a QA process where we do the treatment on the treatment machine to a phantom. Okay.
Right.
It's the final step because we need to make sure that whatever we have planned on the CT scan using computers is what the patient is going to get on the machine. So we deliver the radiation dose to the phantom, and
My
that
good.
phantom has these radiation detectors inside or a film inside, which measures the dose uh, as to how much dose that patient is going to get. So we match all of that. Then we bring the patient, start the radiation. So the process is multiple steps, several things which happen. But all of this has become shortened because of technology. A lot of mapping can be done automatically using AI, using some of the other algorithms. So things have improved that way and shortened the whole course of planning.
Wow. And tell me, from all the developments that we're hearing about in cancer care, what are you most excited about that's coming up or that already exists?
No, I think no most excited about is the personalization or the curation of treatment based on the individual patient. So that's where we are moving towards the molecular side or the genetic side of cancer research, where what we are doing now is we're taking the pathology specimen or blood from the patient to see what is going to be the best treatment for this patient. How much radiation dose does this patient need? Does this patient need chemotherapy or immunotherapy or anything else? And what are the chances? So I think that personalization is what I'm excited about because it treats patients individually based on their cancer.
So I did an interview on gene therapy, and even that blew me away because he was saying potentially in the next 15 years, we could be removing the cancer gene from people before they get it.
Yeah, in certain cancers which are or genetically induced because of mutations, there is definitely potential to change some of that. But there are some cancers which are happening because of the environment or because of patient's habits, right, or person's personal habit or the surroundings. And those will be hard to treat, obviously, and that's why this personalization and treatment is important.
Right.
But definitely a lot of research which is happening to look at it or look at the treatments at a more molecular and genetic level.
And tell me, I would love to hear some stories where, you know, the treatment you do, the precision radiation, where it's even blown you away, where you felt, oh my God, how is this possible?
Yeah, so there are lots of stories, in general. Obviously, I've treated thousands of patients over the last 25, 30 years. And there are lots of wins, and then there are some losses, right? So it keeps you humble,
Yes.
because obviously there is a lot which needs to be done. But on a regular basis, you see patients who have been cured of their cancers, and you're seeing them 15 years, 20 years down the road. They're sending their family members to you. They are happy, they're appreciative. So it's a mixed bag, but a lot of positive and good stories, especially in cancers where you didn't expect the response. Because there are certain cancers, that there will be a 90% response or 100% response, or close to 100% response, I should say. And then there are
Right.
some cancers where is going to be 25% response, 30% response. So when they respond and when you see the cancer has gone away,
Mm-hmm.
it's very heartening. In fact, in old days there were certain cancers, like cancers of the kidney, renal
Right.
cell cancers, or cancer of the skin, like melanomas, where
Mm-hmm.
people thought that these are radio resistant because they would not respond to standard radiation, the standard radiation given over 8 to 9 weeks.
Mm-hmm.
But then with research, we saw that when you do higher doses every day, when you treat them in 3 days or 5 days and deliver high dose of radiation, which now we can do with this precise and stereotactic radiation, these tumors also respond. So a recent advancement is that we now even treat kidney cancers with radiation without any surgery, which 5 years ago, 10 years ago was not possible.
Wow.
So yeah, so some of those things are definitely mind blowing, and advantages of research and technology we are seeing.
And tell me, we were saying that there's very few side effects of this kind of precision radiation. So people could go home after 3 or 5 treatments and just lead a completely normal life?
Yes, most of the time there could be some acute effects because of the swelling in the region or inflammation in the region.
Mm-hmm.
And patients might say, oh, it hurts, or it's uncomfortable. But majority of those acute side effects go away within 4 to 6 weeks of radiation. And those acute side effects, most of the time, are not severe to affect the quality of life in a significant way. Depends on how big of an area you're treating and what region you're treating, as I said, because every area has structures which have different tolerances to radiation.
Right.
But in certain cases, in a lot of cases, for example, as we were discussing in prostate, patients come, go get radiation, go home. A lot of patients don't feel anything. They
Amazing.
basically sometimes ask, doc, did you do anything? Because I didn't feel really anything except for a little burning and urination, which was very minor. So that's where we are moving towards, and they go about their normal life and routine immediately.
You know what amazes me is when I meet oncologists and radiation therapists and things like that, what amazing work you do and how many lives you save. So we're so grateful for the sort of thing you do.
It's very exciting, and as I said, it's a mixed bag. There's a lot more work to be done, but it's a very exciting time to be in this field.
One lifestyle habit that can make recovery easier.
That's a
Actually,
great
give
question.
me 5 lifestyle habits because that is,
Yeah.
yeah, very useful for
Yeah.
people.
And something which I've been very actively involved over the last 5 years, especially the nutrition part in cancer. And so, if you ask me, the two main are physical activity and exercise. So patients have this much misconception that, oh, I have cancer, I'm getting cancer treatment, I should just rest.
Mm-hmm.
That is a misconception because you need to be physically active. Lots of studies have shown that people who are physically active, in fact, going to the gym, doing some strenuous exercise, even for a few minutes, is helpful.
Okay.
So, physical activity, nutrition is another. How do you maintain nutrition? High protein diet, making sure all the nutrients are there in your diet. Taking some of the superfoods which help in healing. So that's
Mm.
another big thing. Always ask for a dietitian. The
Mhm.
third is stress, right? How do you cope with stress? And that I think really or proper counseling, spending time with the physician, asking the right questions helps in that. Fourth is sleep. Right? Sleep is obviously highly important uh, because as you're sleeping, you recover, your body recovers very well. That's the fourth. And the fifth, in general, I think is mindfulness. And it's
Mm.
connected to obviously stress and sleep also,
Yes.
right? So those are the things where, I would say to focus on during the treatment. And keeping a positive attitude in general definitely helps.
So, Dr. Garg, very few oncologists talk about what you're talking about. And again, in the podcast, we talked about it and how difficult it is because patients have to go to like 6, 7 different people to get all these different things. And, one of the people I spoke to, she's trying to do an integrated cancer care center so that people get access to all this in under one roof, which is probably making their life much easier.
Yes, yes, and that's something which a lot of cancer centers are trying to develop this coordinated care. So
Mhm.
first of all, patient knows that these are the things, how their journey is going to be, because now the treatments sometimes can go for months. Right?
Yes.
Some patients are getting this targeted therapy, that surgery, radiation, a combination of things. So how the journey is going to be, and then how the lifestyle factors, as we were discussing, how they are going to be integrated into all of this, because patients want to know what can they do. There's something
Right.
where patients ask, okay, doc, you're going to do the treatment and I trust you, for example, I understand, but what can I do? So
Mm.
that's where I like to discuss with them nutrition, physical activity, mindfulness, sleep, all of these other things which they can do, which now science is showing improves outcomes, both in quality of life and how they're going to beat the cancer overall.
So let's do a quick rapid fire round before we end. So I'm going to ask you a question and just try and give me as short an answer as possible. One misconception about radiation therapy you wish would disappear.
Just one misconception, I would say the misconception that radiation causes, all sorts of radiation causes side effects, which is not true.
Okay. I would say another one is probably that it always has to be a long course. A lot of people I know think there's going to be a really long course of radiation.
Oh, yes, absolutely. Absolutely. Yes.
One question every cancer patient should ask before choosing treatment.
What are my options? Because most of the cancer treatments now will have multiple options. So it's always good to ask for various options and always get a second opinion before starting treatment.
Okay. One thing patients often underestimate about radiation therapy.
The curative potential of it. A lot of people think radiation is only for palliation, or it's going to stabilize the cancer, or will, not really cure it. But a lot of cancers nowadays will get cured or disappear with radiation.
Yes, I think you're absolutely right there. People don't realize that radiation is enough to sort out a lot of, because previously it wasn't, right? They used to combine it with chemo. Um, the biggest change you have seen in cancer treatment during your career?
I think the biggest change is the advancement in technology and how quickly are we able to adopt new treatments because of that. And the personalization of care
Okay.
as well.
What gives you hope about the future of precision cancer care?
The advancements which are coming. So last year in 2025, we had 17 new cancer treatments approved. So it's more than one new cancer treatment getting approved every month. This
Amazing.
used to be 15 years ago, this used to be one or two in a year, right? That would be a big thing. So that advancements and the speed with which this is happening is very, I think, promising, and I feel very optimistic about beating cancer or at least making it a chronic disease in the near future.
So, of these 17 treatments, which of the cancer treatments are you most excited about? The ones that came out last year.
Some of some of the cancers where we had very little hope, like pancreatic, for example, there's very little hope, very few treatments. There's a new treatment now for pancreatic, this targeted therapy, which is shown to improve the outcome. Some preliminary, very promising results. So that's something which is really good. Then some cancers of the blood, some cancers of the brain. So there are a bunch of advancements in some of the diseases where or the cancer types where there was little hope.
Wonderful. Thank you so much for this conversation, Dr. Garg. I'm just blown away by what you've talked about today. And what I'm taking from this conversation is that radiation therapy has changed far more than so many of us realize. Even those of us connected to the field didn't know about it. And it's no longer whether someone receives treatment, but it's about what kind of radiation is right for them, how precisely it needs to be delivered, how many sessions are needed, what organs need to be protected, and what matters for that person's quality of life. So, and thank you for highlighting to us how cancer care has evolved into something which is very, very personalized, and also for highlighting to us that people should ask what their options are, because that's very important. And not just take the surgeon's word for the word of God. Yes, and thank you again for being here and for making time to be here.
It's a pleasure, and thanks for doing this. This is a wonderful forum.
Thank you. I hope we reach lots and lots of people, and I hope we manage to help lots of people. And to those of you listening in, if this has helped you in any way, or if it's something you didn't know about, please share it with friends, family, with someone it could help. I know cancer's still a scary word, but it doesn't have to be with all the treatments that exist. Please subscribe to Wellness Curated as well. This podcast is available completely free. And your support helps us continue to have meaningful conversations like the one we're having today. I'm Anshu Bahanda, and as in everything else, I try and simplify things as much as possible so that you can be more aligned in all your decisions, medical or otherwise, and life flourishes when you're aligned. Thank you.